Here we got our circulatory chapter that continues into shock. Our learning objectives again in an organized fashion, ID and treat any immediate life threats. In organized fashion, obtain an accurate history, perform an examination, and this will help us to become more organized in formulating a diagnosis and creating a differential diagnosis, and then refining this differential diagnosis list. And as we go through these, we want to make sure we use our AMLS pathway. We're looking at a small diagram, but what we're trying to go back to is our cardiovascular chapter, saying that we have the pump, we have blood vessels, then we have blood, and we need this to be working in unison with the respiratory anatomy so that we can get the red blood cells saturated with oxygen as it then is pumped throughout the body. There are some factors that help us to maintain this pressure and homeostasis. We end up having ventilation, which we talked about was how much tidal volume per breath per minute, and we can increase this, and we can also increase the cardiac output. We can cause some vasoconstriction in the sympathetic tone when we are dealing with a patient that is in shock. Additional things on the sympathetic nervous system, we may see the adrenal gland start secreting norepinephrine, and epinephrine is causing an increase in our betas and our alphas, causing vasoconstriction and increase in heart rate. We'll start looking at ADH coming from the posterior pituitary holding onto water, and then we have the renin-angiotensin system secreting renin, and then its potency as it becomes converted into through the ACE in the lungs, we end up having potent vasoconstrictor angiotensin 2, and then we also have some stimulation of aldosterone, which also retains sodium. So we're playing this balance by maintaining the body's homeostasis by increasing blood pressure. So here we have just a kind of diagram flow of what we just kind of talked about, increasing to maintain decrease in blood pressure, to try to compensate for these mechanisms. We have RAS system, we have the posterior pituitary, we also have sympathetic nervous system kicking in. Then we have, as the person's blood pressure goes down though, and we're unable to compensate, we become decompensated. We fall into these decompensated shocks, and we become more disorganized and disoriented, and we see that the body is trying to maintain this homeostasis but is unable to, and blood pressure and vital signs start to continue to drop, and we fall into decompensation. And these types of shocks are usually related to one of these four, as we talked about it in the cardiovascular case, and each one is kind of treated a lot differently. We know that we're going to try to tank them up in most cases, and then in some cases we may use some vasoconstrictors, and other ones we may think about specific treatments to try to reverse these agents or our etiologies that are causing this. And in some of the obstructive ones, we have actually life-saving measures that we want to deploy immediately to get our patients to go back to homeostasis. So let's go over our first case here. We're dispatched to a person that's 62 years old. They're ill. This is an apartment building at 6 p.m. When we come there, we're already thinking that, geez, what else do we need? How far are we from the hospital? This is a nursing home. Now we got to walk up, or we got elevators. We got a lot of things to negotiate, and what do we bring on this case? And do we need any additional resources that we need? We still haven't laid eyes on our patient. We really don't know much more other than that. In our idea, we're trying to use our AMLS assessment pathway. It's similar again to our national registry, but we're going to really kind of go down through these steps in an organized fashion. So our initial observation, the scene is safe. We got there, but there are some issues as we have to climb and negotiate through the building, and we're going to have to figure out how to get the patient down, and we want to be safe in using our equipment and making sure we are all safe so that there isn't any issue with injuring ourselves or the patient. As we arrive, we see that the family meets us at the door, and the patient is upstairs. We see some oxygen tubing. Could this patient be on some kind of chronic pulmonary issue or some chronic cardiac condition, being on HOMO too? We still haven't seen the patient, but at least the family's there. We can start giving them some duties to find out where's the meds, any medical information that they can get the ID, kind of give us an understanding of what's going on and what's our patient's name already. So now But we lay our eyes on the patient, he's just laying in bed. It doesn't look very active, but he doesn't look cyanotic, and he looks like his eyes are awake. So we need to start diving in and getting our sample history or our OP-QRST, our history of present illness. Now, it's the patient. So how is he presenting? Is he altered? Can he move? Why is he getting out of the bed? And we can start formulating a differential just based on our assessment, based on our observations that we've seen and what the patient and family has already kind of given to us. In our primary assessment, we find that the patient is lethargic but awake. So slow to respond, a little sleepy, but still arousable. I'm not sure these kind of contradict themselves. Breathing is shallow and tachypnea. It's not that very good. He's hypoventilating and he's trying to compensate for some reason because he's breathing fast. Now, this is a pulmonary or is this something else? Another body system that's causing this increase in respiratory rate, as it could be compensation. Now we look at skin signs and he's compensating there because his perfusion is poor. What are our life threats? Well, he definitely is altered, and we do have some signs that patient is trying to compensate. We definitely have the sick patient. We need to start moving forward, and based on what we got so far, just poor perfusion, increased labored respiratory rate, and some altered mental status. So now we can decide, are we going to chase the AIU tips, this altered mental status type of thing? Are we going to chase it because it's hypoxia? We're going to go through respiratory types of etiologies and medical emergencies, or do we chase down the possibility of the patient being hypotensive just based on the skin findings and poor perfusion status? And is there any chance of anything else? So, trauma. So here are some of the differentials that they are making us think about as we were to use some of those different avenues to take a look at it. And we can tell that even though this is our shock chapter, they pretty much got a lot of other things in there, and we could pretty much move some of those over to life-threatening depending on how our patient either progresses along the way. I mean, and if it becomes less as we treat them, we could move them back down into the non-critical, but I have a sick patient. Now let's get more history on the present illness. As is the gradual onset, and he's got some pain there, and it's a dull ache. We're kind of all over the place, and it's lucky that the patient is able to tell us this. But where do we go from here? It's a headache that the patient is, but he's short of breath and doesn't look that well. Our sampler history, they're using R. And here we have this diagnosis of some kind of type 2 diabetes, so he should be on medications like metformin, so we got that right there. How long has he been on that? Any changes? Could this still be diabetic? So as we start to move over, again, some of us would like to go into history of present illness, OP-QRST, dive into the medical history of meds, allergies, and go to our sample. And other of us would do some type of vital signs and get into our assessment. Heart rate's 122 or 120. Pulse ox not great. CO2 looks like he's kind of blowing that off a little. Respiratory rate though isn't that fast. Blood pressure is low and he's avoid of any fever. Now we probably need to take a look at that EKG and say that we're going to pick that rate up just a little bit more than what's showing on there. Okay. We'll look at more of a detailed exam. So we look for any types of stroke symptoms. Does he have lapse? Is he lapse positive? We should be going over what we're looking for as far as lapse, and if some of you are waiting for our blood sugar is coming up, and here we have blood sugar that falls at a normal. Our cardiac monitor is showing a sinus tach. EKG on the 12 lead shows no ST elevations. WBCs is up a little bit, but it's within a normal. Hemoglobin, hematocrit. Remember we went over these things. We said red blood cell is about 5. Hemoglobin is 15, then hematocrit is going to be about 45, and it seems to be all kind of within a normal. Lactate's up a little bit. Cardiac enzymes are normal. So as we continue on, we want to find out, well, how do we get this patient out? What are we going to do with them? We don't have the other enzymes that we want. We don't have that, and if the cardiac enzymes are showing up normal now, we don't know whether or not they're going to change over time. So we really need to take a look at where we're going. We'll do more of our detailed assessment as we get out. We know that he's got some kind of foot drop on the left side, but they haven't noticed anything. He's taking all his meds. Well, let's take a look and see what are some of our differential diagnoses, and do we think it could be sepsis or pulmonary emboli? What are we looking at? Again, the life-threatening, we haven't pushed anything in there, but the person is disoriented, and we're still in our critical area where we're going to maintain and try to treat this. Think about what you do for your treatment. Again, we're just going to go over some other stages of shock. Is the person compensating, is decompensating, or reversible? Now we see that the lactate is 8. Usually where it's about 2 or just under 2. The lactate was a little elevated, I think, and that make us think that there's something going on. But he's trying to increase his respiratory rate, trying to increase his heart rate. Is that the case? We're not really sure, but he has some signs and symptoms that he's kind of disoriented and going down. So what would be some of our basic BLS measures? What would be some of our ALS measures? And what would we think about treating and taking care of this patient? Now, do we think this is a type of shock that we have gone over? Is there some kind of fashion or some idea that we've missed? What kind of condition that we're looking at? Is this hypovolemic, distributive, cardiogenic, and obstructive? So let's go over those.